Hi, everybody, and welcome to our module on the brachial plexus. The brachial plexus is a network or a web of nerves that derives from the spinal cord. It provides motor and sensory innervation to the arm, and when elements of the nerve plexus are damaged, this is what I want you to know for step one of your board exams. Let me start by reviewing spinal nerve roots in general. There are 8 cervical spinal roots, 12 thoracic, 5 lumbar, and 5 sacral. Now, the confusing part is there are only 7 cervical vertebrae, so how can there be 8 cervical spinal nerve roots? And to understand this, you need to understand the way these nerve roots are named. If we're looking at the cervical spine and we find the C1 vertebrae, the C1 nerve root is going to come off above the C1 vertebrae. And this is going to be the case all the way down until we reach C7, which is the last cervical vertebrae. At C7, we have nerve root C7 come off above that, but we also have nerve root C8 that comes off below that. This is just a peculiarity of the way these nerve roots are named. After this, we move into the thoracic spinal canal. So we've got the first thoracic vertebrae, and the T1 nerve root comes off below that. And then this is the case all the way down the rest of the spinal column. The vertebrae has the nerve root with the same name coming off below it. The only exceptions are up in the cervical spine. So now that we understand that, let's take a look at a drawing of the brachial plexus. So the brachial plexus derives from nerve root C5 all the way down to T1. And the plexus is basically a web of nerves like you see on the screen here, and it can be broken down into the roots, which come off the spinal column, and then trunks, and then divisions, and then cords. And all these structures give off important nerves for the arm. For example, here's the axillary nerve, here's the radial nerve, and we'll go through all these things in the rest of this video. In the anatomy lab, you may have gone to great lengths to identify all the individual components of the brachial plexus. You don't need to know all that for step one. You just need to know the brachial plexus lesions shown on the slide here. There are 5 nerves from the brachial plexus that often develop lesions. You should know those. There are 2 trunk lesions, and finally, the long thoracic nerve can have a lesion. Let's start by talking about the axillary nerve. If we go back to this drawing, this is the axillary nerve. It's an extension of the posterior cord. But notice the way it's drawn in this picture. It comes off sort of the top of the posterior cord. And if you remember that, it's an easy way to remember that most of the fibers for the axillary nerve come from C5 and C6. So even though the posterior cord receives fibers from C5 all the way down to T1, it's the C5 and C6 fibers that largely give rise to the axillary nerve. The axillary nerve is named for the axilla, or the armpit. And if you remember this, it's easy to remember that it innervates structures found near the armpit. One of the major structures found near the armpit is the deltoid muscle. This is a large shoulder muscle. It's the muscle that gets huge in bodybuilders, and it's responsible for much of the abduction at the shoulder. In particular, it's responsible for abduction from 15 to 90 degrees. So you can imagine that patients who have an axillary nerve lesion will have difficulty abducting the shoulder. In addition, the axillary nerve also provides sensation to the skin over the deltoid, so this skin will become numb in patients with an axillary nerve lesion. So ways that this nerve can be damaged involve processes that occur near the armpit. So a fracture of the proximal humerus right near the armpit can damage the axillary nerve. This can happen to an elderly patient who falls onto their shoulder. In addition, if patients have a dislocated shoulder from trauma, for example, during a football game and a tackle, this can lead to anterior displacement of the humerus, meaning the humerus moves out of the joint and forward towards the front of the body. This can damage the axillary nerve and also cause weakness of abduction and loss of sensation over the deltoid. Moving on, now let's talk about the radial nerve. Going back to this picture, the radial nerve is shown here. Like the axillary nerve, it derives from the posterior cord. And the posterior cord receives some nerve fibers from all the levels of the brachial plexus, C5 to T1. Now, in the case of the axillary nerve, we talked about how C5 and C6 were the main nerve roots for the axillary nerve. But in the case of the radial nerve, all the levels from C5 to T1 deliver some nerve fibers that supply the radial nerve. If we look at this picture on the right side of the screen, this is the radial nerve shown here. It wraps around the humerus and innervates muscles in the back of the forearm. The easy way to remember the muscles that are innervated by the radial nerve is to just think of the radial nerve as the major innervator of extensors in the arm, wrist, and fingers. So the radial nerve innervates the triceps, and that will extend the arm at the elbow. It also innervates extensor muscles in the forearm. So on the back of your forearm, you find many muscles that extend the wrist and fingers, and these are all innervated by the radial nerve. In addition, those muscles supinate the forearm, and so this motion requires the radial nerve. And then in addition, it's sensory to the skin at the back of the hand and forearm, and that should make sense if you remember that this nerve also innervates the muscles on the back of the forearm. A brief word on flexion and extension of the wrist. At the bottom of the screen is a flexed wrist on the left and an extended wrist on the right. There are a number of wrist flexor muscles, but two of the important ones are the flexor carpi radialis and the flexor carpi ulnaris. They are innervated by the median and ulnar nerves. In terms of major extensors, those are shown here on the right side of the slide, and they are all innervated by the radial nerve. What this means is when you lose your radial nerve, these flexors will dominate and the wrist will assume a position like what's shown on the left side of the screen. That's called wrist drop, and that's the hallmark of a radial nerve lesion because you lose the extensors and the wrist flexors dominate. So now let's talk about some of the clinical findings you could see in a radial nerve lesion. First of all, the triceps muscle may show weakness. This especially happens when the injury to the radial nerve is high up in the axillary area. Remember that the triceps extends at the elbow, so this is going to present as difficulty extending at the elbow. And then as I told you on the last slide, wrist drop is a classic finding in a radial nerve lesion that's shown on the screen here. That's because of weakness of the wrist and finger extensors. And then finally, in a radial nerve lesion, you can see sensory loss to the back of the hand and forearm. The areas shown in red in this picture at the top right side of the screen here are all innervated by the radial nerve. Some causes of radial nerve lesions are shown on this slide. A fracture of the humerus, classically at the mid shaft, which is this portion right here, may cause a radial nerve palsy. Patients who are on crutches can compress the radial nerve where it runs in the upper arm. And then patients who sleep with their arms out over a chair, alcoholics sometimes do this if they pass out. These patients can develop a radial nerve palsy. This is sometimes called a Saturday night palsy. This can also happen if someone passes out with their head on their upper arm and compresses the nerve that way. Now, the lesions of the radial nerve are a little bit different depending on whether the nerve is injured up near the axilla or down closer to the elbow. And to understand this, you need to appreciate that the radial nerve runs adjacent to the humerus in something called the spiral or radial groove. It's also called the radial sulcus. It's found on the humerus bone, and the radial nerve runs there. And for this reason, the radial nerve is vulnerable to compression against the humerus bone in this location. If there is a radial nerve lesion at the and Henderson compresses the nerve that way. Now, the lesions of the radial nerve are a little bit different depending on whether the nerve is injured up near the axilla or down closer to the elbow. And to understand this, you need to appreciate that the radial nerve runs adjacent to the humerus in something called the spiral or radial groove. It's also called the radial sulcus. It's found on the humerus bone, and the radial nerve runs there. And for this reason, the radial nerve is vulnerable to compression against the humerus bone in this location. If there is a radial nerve lesion at the level of the axilla, so that's very high up in the arm, this will lead to motor and sensory loss in all the areas supplied by the radial nerve. So there will be triceps muscle weakness, which will present as difficulty extending the arm at the elbow. There will be weakness of the wrist and finger extensors, and there will be sensory loss at the back of the hand and the back of the forearm. If the lesion is lower down, such as in the radial groove, however, the findings are different. In this situation, the triceps muscle is spared, but there will still be weakness of the wrist and finger extensors. In addition, this area shown in red is also usually unaffected. That's because it's supplied by branches that are given off before the radial groove. The only sensory findings are due to damage to the superficial branch of the radial nerve, which supplies the back of the hand right here. So patients who have a radial groove lesion have normal triceps muscle, in other words, normal extension at the elbow, and they do not have sensory loss at the back of the forearm. Moving on, our next next nerve that derives from the brachial plexus is called the musculocutaneous nerve. This comes off the lateral cord of the brachial plexus, derived from nerve roots C5, C6, and C7. If we go back to this drawing, this is the musculocutaneous nerve shown here. It comes from the lateral cord, and the lateral cord receives innervation from C7, C6, and C5. This muscle innervates the biceps. That's the major muscle you should think of as associated with the musculocutaneous nerve. This is a picture of a man doing a biceps curl to remind you that the biceps flex at the elbow. The musculocutaneous is also sensory to the lateral forearm. If you look at this picture at the top right side of the screen, this area shown in brown is innervated by the musculocutaneous nerve. So if a nerve lesion of this nerve occurs, which is relatively rare, you will see weakness of elbow flexion and sensory loss to the lateral forearm. Going back to this slide, we've now talked about nerve lesions of the axillary, radial, and musculocutaneous nerves. And I'll talk about the median and ulnar nerves in the video on the hand because they're the major nerve supply to the hand. So now I'm going to talk about lesions to the trunks of the brachial plexus. And you can basically think of two trunk lesions. One is an upper lesion and one is a lower lesion. On this slide, you can see that there is an upper trunk of the brachial plexus formed by C5 and C6, and we'll talk about what happens when there's a lesion of that trunk. There's also a lower trunk here, which receives fibers from C8 and T. Now I'm going to talk about lesions to the trunks of the brachial plexus. And you can basically think of two trunk lesions. One is an upper lesion and one is a lower lesion. On this slide, you can see that there is an upper trunk of the brachial plexus formed by C5 and C6, and we'll talk about what happens when there's a lesion of that trunk. There's also a lower trunk here, which receives fibers from C8 and T1. A C5, C6 trunk lesion is also called an Erb's palsy or an upper plexus injury, and this type of brachial plexus injury is caused by excessive angle at the neck or shoulder where the brachial plexus originates. This stretches or tears the nerve roots, and that leads to nerve damage. And the classic cause of this type of trunk injury is birth trauma. Many babies experience what is known as shoulder dystocia. This means the shoulder impedes delivery through the vaginal canal. So when the baby is ultimately delivered, the baby may have stretching of the angle between the neck and the shoulder, and this can lead to an upper plexus injury. When there's injury to the upper trunk, this affects nerves that derive from the upper trunk. So this includes the axillary nerve, which, as we talked about before, innervates the deltoid muscle that you need for abduction. So a baby with an upper trunk injury will have the shoulder flat at the side with the upper arm pressed against the chest. In addition, the upper trunk supplies the musculocutaneous nerve, which, as we talked about before, innervates the biceps muscle that you need for flexion at the elbow. So because of this, the elbow will be straight in a baby with an upper trunk injury, and the forearm will be down at the side, just like the upper arm. And then finally, the upper trunk supplies the suprascapular nerve, which innervates the infraspinatus, which is important for external rotation. So the baby won't be able to externally rotate the arm, and therefore the arm will be internally rotated. So if you put all those lesions together, what you get is something like this picture shown on the screen here. The baby will have the arm straight down at the side. It will be straight at the elbow, and the baby can't abduct, so the upper arm is against the chest. And then the arm is internally rotated, meaning the hand is facing out or backwards. And this is sometimes called the waiter's tip because it looks like a waiter who's putting his hand behind him so that he can receive a tip. And if we go back to this picture, I just want to show you where all these nerves are. So this is the suprascapular nerve here. Down here, we have the musculocutaneous and axillary nerve. They all derive from C5 and C6, and that's why all of these can be dysfunctional when you have an upper trunk injury. Next, let's talk about a C8 to T1 trunk injury. This is also called a Klumpke palsy or a lower plexus injury. This type of brachial plexus lesion is usually caused by excessive abduction of the arm. The classic way for this to happen is for someone to fall from a tree branch, like this girl shown on the screen, and then try to catch another tree branch to prevent themselves from falling. The arm is then yanked outwards and upwards. That's abduction, and that can cause a C8 to T1 trunk injury. You can also have a brachial plexus lesion is usually caused by excessive abduction of the arm. The classic way for this to happen is for someone to fall from a tree branch, like this girl shown on the screen, and then try to catch another tree branch to prevent themselves from falling. The arm is then yanked outwards and upwards. That's abduction, and that can cause a C8 to T1 trunk injury. You can also see this from birth trauma, but it's much more rare compared to an upper trunk injury. The major nerves that are affected by a lower plexus injury are the ulnar and median nerves, and this will impact the intrinsic hand muscles. In the video on the hand, I talk about this in more detail, but the intrinsic muscles of the hand are supplied by the ulnar and median nerves. Now, I told you earlier that the flexors at the wrist are supplied by the ulnar and median nerves, but they're usually not part of a lower plexus injury. That's because they are spared because they're innervated by different roots than the C8 to T1 roots that supply the lower trunk. I'll show you a picture of that in a second. So what you get in a lower plexus injury or a Klumpke palsy is the clawed hand shown in the picture here. And it is a complete clawed hand. In an ulnar or median nerve syndrome, you could have half of the hand affected to form a claw, but in a trunk injury, you have the entire hand forming a claw, as is shown. This happens because the MCP joints are hyperextended and the interphalangeal joints are flexed, and that's what gives you the claw hand. And in the video on the hand, I talk about why the hand assumes this position in nerve injuries in more detail. And I just want to show you here that the lower trunk, which is C8 and T1, supplies the median and ulnar nerves, and that's why they are the major nerves that are impacted. However, these nerves also derive some innervation from other roots, like through the lateral cord, and that's why you can see some muscles retain their innervation even when the lower plexus is injured. Now let's talk about the thoracic outlet syndrome. This syndrome occurs when there is compression of nerves and vessels as they leave the thorax. The place where this occurs is above the first rib and behind the clavicle. This section of the body is called the thoracic outlet. There's a picture of it on the screen here. So we've got a rib here at the bottom. We've got the clavicle right here. And between those two bones, we've got a number of nerves as well as arteries and veins. And if they become compressed, that can lead to the thoracic outlet syndrome. The anatomic location where these nerves and blood vessels become compressed is called the scalene triangle. This is a triangle formed by two muscles, the anterior and middle scalene, and above the first rib. If you look at this drawing on the screen here, we've got the first rib along the bottom running below the nerves and blood vessels. Then we've got the middle scalene here and the anterior scalene here, and this forms a triangle. Where these nerves and blood vessels become compressed is called the scalene triangle. This is a triangle formed by two muscles, the anterior and middle scalene, and above the first rib. If you look at this drawing on the screen here, we've got the first rib along the bottom running below the nerves and blood vessels. Then we've got the middle scalene here and the anterior scalene here, and this forms a triangle through which the nerves and blood vessels course. It's very high yield to know why some individuals are predisposed to the thoracic outlet syndrome compared to others. One of the most common rib. If you look at this drawing on the screen here, we've got the first rib along the bottom running below the nerves and blood vessels. Then we've got the middle scalene here and the anterior scalene here, and this forms a triangle through which the nerves and blood vessels course. worse. It's very high yield to know why some individuals are predisposed to the thoracic outlet syndrome compared to others. And one of the most common reasons for this is the presence of a cervical rib. This is an anomalous extra rib from the seventh cervical vertebrae. If you look at this drawing of the rib cage on the top right side of the screen here, normally the first rib comes off the first thoracic vertebrae, and there are no ribs above this level. However, some individuals are born with a rib coming off the seventh cervical vertebrae, and this predisposes to the thoracic outlet syndrome. This often occurs if someone who has a cervical rib suffers a hyperextension flexion injury. This is often called a whiplash injury. This can lead to development of the thoracic outlet syndrome by compressing those nerves and blood vessels. If you look at the bottom left side of the screen here, this is a 3D CT scan showing a cervical rib right here coming off the seventh cervical vertebrae. You can also see them in these x-rays here. I'm highlighting it in this x-ray in the middle of the screen here. There's also a cervical rib shown bilaterally in this x-ray on the right side of the screen here. Anytime someone is born with one of these ribs, they are at risk for the thoracic outlet syndrome if they have the right kind of injury. The clinical features of the thoracic outlet syndrome include injury to the brachial plexus. It's usually a lower plexus injury, so the patient presents with a Klumpski palsy and the claw hand like we talked about before. And the symptoms are often worse with elevation of the arms or hands because this compresses the nerve to a greater degree. In addition to the nerve injury, however, there will be symptoms related to vascular compression. So usually the thin-walled veins are compressed, and this leads to a swollen arm. In addition, there can sometimes be arterial compression, although this is rare. This can lead to ischemia of the hand, where the hand is painful and pallorous and cool to the touch. There can be a lower systolic blood pressure in the affected arm, and the distal pulses can be weak. But the way to recognize this in a board question is that it will be a brachial plexus injury in addition to evidence of vascular compromise like arm swelling or ischemia of the limb. I'll finish with this slide on the long thoracic nerve. If we go back to this slide, this is the long thoracic nerve. It derives innervation from C5, C6, and C7, and you can see that it comes off very early in the brachial plexus before the development of trunks, divisions, and cords. The main thing to know about this nerve is that it innervates the serratus anterior muscle, which pulls the scapula against the rib cage. This is a picture of the serratus anterior shown in the bottom right side of the screen here. So if there's a lesion to this nerve, which sometimes happens from trauma, this will lead to winging of the scapula, where the scapula sticks out from the back. This is a picture of a winged scapula shown on the screen here. The way you usually demonstrate this clinically is to ask the patient to press their outstretched arm against the wall. When they do this, that will lead to the scapula protruding from the back, and that's the way you can uncover winging of the scapula in a long thoracic nerve lesion. And that concludes our video on the brachial plexus. Hello, everyone, and welcome to our module on the wrist. Let's start by talking about the wrist bones. The word carpus means wrist. And then, hello everyone, and welcome to our module on the wrist. Let's start by talking about the wrist bones. The word carpus means wrist, and there are 8 carpal or wrist bones. Their names are shown on the slide here with a letter that corresponds to the X-ray image on the right side of the screen. 4 of the bones are considered the proximal carpal bones. Those are A, B, C, and D. This group includes the scaphoid bone, which is the most commonly injured carpal bone. The other 4 bones are called the distal carpal bones. So let's talk about the scaphoid A, B, C bones. Their names are shown on the slide here with a letter that corresponds to the X-ray image on the right side of the screen. 4 of the bones are considered the proximal carpal bones. Those are A, B, C, and D. This group includes the scaphoid bone, which is the most commonly injured carpal bone. The other 4 bones are called the distal carpal bones. So let's talk about the scaphoid bone. This is the most commonly fractured carpal bone, and you can palpate your scaphoid bone in your anatomic snuff box, which is a depression on the back of your hand circled here in this picture on the top right. Snuff is a form of tobacco, and some people inhale it by placing a little bit of it in the anatomic snuff box. This bone is classically injured in what's known as a Fuchs injury. A Fuchs injury is a fall on an outstretched hand, and that can lead to a scaphoid bone fracture. An example of an X-ray of a scaphoid fracture is depression of the distal carpal. Bones. So let's talk about the scaphoid bone. This is the most commonly fractured carpal bone, and you can palpate your scaphoid bone in your anatomic snuff box, which is a depression on the back of your hand circled here in this picture on the top right. Snuff is a form of tobacco, and some people inhale it by placing a little bit of it in the anatomic snuff box. This bone is classically injured in what's known as a Fuchs injury. A Fuchs injury is a fall on an outstretched hand, and that can lead to a scaphoid bone fracture. An example of an X-ray of a scaphoid fracture shown at the bottom right side of the screen here. You can see that there's a crack through the middle of the scaphoid bone, which sits right on top of the radius. And there are 2 classic complications of scaphoid fractures you should know for your boards, and those are avascular necrosis and non-union. The scaphoid bone sits right on top of the radius, and if you know that, it's an easy way to remember that the radial artery is the blood supply to the scaphoid bone. It gives off branches called palmar and dorsal branches that deliver blood to the scaphoid. But the way this works is that the artery delivers blood to the distal portion of the scaphoid, and then blood works its way back proximally. What this means is if you have a fracture, especially a fracture in the middle of the bone, then this proximal portion is going to lose its blood supply. That's because the proximal portion relies on retrograde flow. So for this reason, avascular necrosis is a classic complication of a scaphoid fracture. This is loss of blood supply to the bone. This is especially common in waist fractures. So looking on the screen here, this is the waist of the scaphoid bone, and a fracture here can cut off blood supply to the proximal bone and lead to avascular necrosis. And then because of avascular necrosis, sometimes scaphoid bones have what's known as non-union. This is failure of the bone to heal, and this also happens because some of the bone has lost its blood supply. The scaphoid is the most important wrist bone for you to know about for your boards, but if you want to know about one other, know about the lunate bone. So the lunate bone is B in this image on the screen here, and it sits right on top of the radius. And a lunate bone dislocation can occur from trauma or a fall.
The reason for this is because the lunate is attached to the radius, and you can remember that easily if you know that it sits on top of the radius. So sometimes in a fall, the wrist bones will be forced backwards, meaning away from the palm, but the lunate, because it's attached to the radius, will be held forwards and displaced toward the palm. The dislocation can occur from trauma or a fall. The reason for this is because the lunate is attached to the radius, and you can remember that easily if you know that it sits on top of the radius. So sometimes in a fall, the wrist bones will be forced backwards, meaning away from the palm, but the lunate, because it's attached to the radius, will be held forwards and displaced toward the palm. This is called a lunate dislocation. And the patient will present with a wrist that is painful and swollen, and on x-ray, the lunate will be dislocated towards the palm. This is an uncommon wrist injury, but the main reason they may ask you about it on your boards is because the lunate sits right on top of the carpal tunnel. So when it is displaced anteriorly, it can compress the carpal tunnel, and that can lead to median nerve dysfunction. Board with a wrist that is painful and swollen, and on x-ray, the lunate will be dislocated towards the palm. This is an uncommon wrist injury, but the main reason they may ask you about it on your boards is because the lunate sits right on top of the carpal tunnel. So when it is displaced anteriorly, it can compress the carpal tunnel, and that can lead to median nerve dysfunction. So that's a nice segue into carpal tunnel syndrome, which we'll discuss next. And let's begin by defining the carpal tunnel. So I told you that the word carpal refers to the wrist bone. So the carpal tunnel is a tunnel near the wrist bone. So if you look at this drawing on the screen, these are the wrist bones on the back of the hand. This is the palm of the hand. And just under the skin of the palm of the hand is a structure called the flexor retinaculum. It's also called the transverse carpal ligament. And between this ligament and the bones, you find the carpal tunnel, and that is where the median nerve runs. And therefore, if the carpal tunnel becomes compressed for any reason, the median nerve can become abnormal, and that can lead to median nerve dysfunction. So carpal tunnel syndrome is entrapment of the median nerve in the carpal tunnel, and patients present with symptoms of median nerve dysfunction. In the video on the hand, I talk about median nerve lesions in detail, but I'll briefly review the findings of a medial nerve lesion here, the type of findings you can see in carpal tunnel syndrome. So the median nerve provides motor innervation to the thumb side of the hand. So in a median nerve lesion, you can see motor loss to the thumb side. This can include problems with thumb movement. That's because the thenar muscles are innervated by the median nerve and they move the thumb. This can also include problems on flexion and extension of the lateral fingers. Those are the two fingers closest to the thumb, and that's because the lumbrical muscles are also innervated by the median nerve for the lateral fingers. In terms of sensory symptoms, the median nerve provides sensory innervation to the thenar eminence and the lateral 3.5 fingers. If you look at this picture at the bottom of the screen here, this is the palm side of the hand. Everything in brown here is sensory innervated by the median nerve. Now, a special point on carpal tunnel syndrome, there is a small branch of the median nerve that comes to the finger. Can also, so in a immediate view, the findings of a medial nerve lesion here, the type of findings you can see in carpal tunnel syndrome. So the median nerve provides motor innervation to the thumb side of the hand. So in a median nerve lesion, you can see motor loss to the thumb side. This can include problems with thumb movement. That's because the thenar muscles are innervated by the median nerve and they move the thumb. This can also include problems on flexion and extension of the lateral fingers. Those are the two fingers closest to the thumb, and that's because the lumbrical muscles are also innervated by the median nerve for the lateral fingers. In terms of sensory symptoms, the median nerve provides sensory innervation to the thenar eminence and the lateral 3.5 fingers. If you look at this picture at the bottom of the screen here, this is the palm side of the hand. Everything in brown here is sensory innervated by the median nerve. Now, a special point on carpal tunnel syndrome, there is a small branch of the median nerve that comes off before the carpal tunnel and does not run through the carpal tunnel, and it provides sensory innervation over the thenar eminence right here. So for this reason, in the carpal tunnel syndrome, you usually see sensory loss on the palmar side of the lateral fingers, but not over the thenar eminence. That's a special thing that has to do with carpal tunnel syndrome and median nerve problems that result from that syndrome. So when the median nerve is compressed in the carpal tunnel, that leads to the carpal tunnel syndrome. This usually begins with sensory symptoms. If it's untreated for a long period of time, it can progress to motor symptoms, but in modern practice, motor symptoms are very rare because people usually come to medical attention before this happens. The classic hallmark is pain or paresthesia, is usually described by the patient as numbness or tingling in the distribution of the median nerve. So remember, this is going to involve the lateral fingers near the thumb, but it's not going to involve the thenar eminence. Those are the classic findings in the carpal tunnel syndrome. So who is at risk for carpal tunnel syndrome? Well, for years, it was thought that if you have a job where you repetitively use your hands or wrists, this could cause the carpal tunnel syndrome. So for example, especially people who sit at a desk and type all day, it was thought that that activity led to the carpal tunnel syndrome. This is controversial, however, because a lot of studies have not borne this out. Other risk factors are shown in this slide. Obese patients are more likely to get the carpal tunnel syndrome. Pregnant women may develop this syndrome. It's thought to be because of edema around the carpal tunnel. And then other risk factors include some other disorders like diabetes, rheumatoid arthritis, and hypothyroidism. There are a couple of rare disorders that are strongly associated with carpal tunnel syndrome, and these are the things that are very high yield for you to know for your boards. The first one is acromegaly. Acromegaly is caused by growth hormone excess in an adult. This is often caused by a pituitary adenoma, and I talk about acromegaly in more detail in the endocrine video on the pituitary gland. But patients who develop a growth hormone excess in acromegaly will have their jaw grow and they will develop coarse facial features. But in addition, their hands and feet will grow. This is a picture of a patient with acromegaly on the bottom of the screen here. This is the patient with acromegaly. This is a normal hand on the left. You can see how the hand is much bigger. That's caused by growth hormone excess. A classic sign of acromegaly is a patient who says their glove or shoe size has gone up in the last year or so. They may complain that their rings no longer fit, and then up to a third of patients with acromegaly develop carpal tunnel syndrome. It's high yield to remember that, and it's easy to understand. Their hands are getting bigger, and this can lead to compression of the median nerve in the carpal tunnel. Another high yield cause of carpal tunnel syndrome you should know about is dialysis-related amyloidosis. I talk about amyloidosis in a video in the hematology section. There are a number of forms of amyloidosis, but in a dialysis-related form, amyloid deposits form from beta-2 microglobulin, which is a component of MHC class 1, as shown on the screen here. This is a complication of renal failure. That's why it's called the dialysis-related form of amyloidosis. It happens to people who are on dialysis. And the reason it occurs is because dialysis does not effectively remove beta-2 microglobulin, so it deposits in bones, joints, and tendons and causes amyloidosis. This can cause shoulder pain because it likes to deposit in the joints of the shoulder. It also often causes carpal tunnel syndrome. So many patients who are on dialysis for end-stage renal disease develop carpal tunnel syndrome, and this is often the mechanism. It's because of dialysis-related amyloidosis. There are a couple of classic maneuvers that you can do at the bedside for carpal tunnel syndrome. One is called eliciting Tinel's sign. To elicit this sign, you ask the patient to extend their wrist, and then the clinician percusses or taps lightly over the thumb side of the wrist. If the patient notes tingling in the distribution of the median nerve, this is a positive test for carpal tunnel syndrome. The other maneuver is called the Phelan maneuver. In this maneuver, the patient is asked to flex their wrist and hold it for a minute. If they develop tingling in the distribution of the median nerve, that is a positive test. Now let's talk about Guyon's canal, which is also called the ulnar canal. This is the ulnar nerve equivalent to the carpal tunnel for the median nerve. Guyon's canal is the other maneuver is called the Phelan maneuver. In this maneuver, the patient is asked to flex their wrist and hold it for a minute. If they develop tingling in the distribution of the median nerve, that is a positive test. Now let's talk about Guyon's canal, which is also called the ulnar canal. This is the ulnar nerve equivalent to the carpal tunnel for the median nerve. Guyon's canal is how the ulnar nerve gets into the hand, and it can become compressed and lead to ulnar nerve dysfunction. Guyon's canal is found above the transverse carpal ligament, and the roof is formed by the palmar fascia. And the fact that it's above this ligament is very high yield for you to know. This is an important distinction between Guyon's canal and the carpal tunnel. Let's look at this drawing on the screen here. These are the carpal bones here, and this is the median nerve found in the carpal tunnel, which is below the transverse ligament shown here. The ulnar nerve is found above the transverse ligament. That's Guyon's. canal. It's between the transverse ligament and fascia of the palm up here. And this is where the ulnar nerve passes into the wrist. And if this canal becomes narrowed or compressed, that can lead to ulnar nerve lesions. In the video on the hand, I discussed the clinical findings of an ulnar nerve lesion in detail, but I will briefly review them here. First of all, in terms of motor function, you can lose abduction and adduction of the fingers because this is done by the interosseous muscles, which are innervated by the ulnar nerve. You can also have motor loss to the little finger side of the hand, including the little and ring fingers. This is because the hypothenar muscles and the median two lumbricals are innervated by the ulnar nerve. And then finally, you can also see sensory loss on the little finger side of the hand. If you look at this picture on the screen here, everything shown in blue on the palm side here and the dorsal side here is innervated by the ulnar nerve, so you can have sensory symptoms in those regions. Guyon's canal syndrome is the clinical finding of an ulnar neuropathy at the wrist caused by compression of the ulnar nerve in Guyon's canal. It's often seen in people who overuse the wrist. In many cases have been reported among bicyclists. This is thought to result from direct pressure on the wrist on Guyon's canal from the handlebars. I'll finish this video by describing two pediatric fractures you should be familiar with. So children often fracture their bones, especially the bones near the wrist and in the forearm, from trauma, but children's bones are softer than adult bones. So children often have incomplete fractures. In other words, the bone doesn't completely snap in two. And there are two classic pediatric incomplete fractures you should be familiar with for your boards. The first one is called a green stick fracture. This is basically a bent bone. There's a fracture, but it does not extend through the width of the bone. It often occurs in the distal radius right near the wrist from trauma, and this happens when there is a bending force from the side that's applied to the bone. It often happens as part of a Fuchs injury, a fall, and an outstretched hand. Here's an example of a green stick fracture shown on the screen here. You can see that the radius bone is bent and that this fracture does not completely extend through the bone, but part of the bone is still attached on the side, and that's what causes it to have this bent formation. That's called a green stick fracture, a classic incomplete fracture seen in children. The other incomplete fracture is called a torus fracture, or sometimes it's called a buckle fracture. This happens from an axial force trauma, meaning a force applied into the bone. So for example, if you look at this drawing of a bone on the screen here, if we applied a force this direction right into the bone, that's what causes a torus fracture. It usually occurs in the distal metaphysis. So some brief terminology of long bones here. The shaft is called the diaphysis, that's the long part here. The epiphysis is the rounded end, and the metaphysis is the widening right before the rounded end. And it's at this metaphysis that the torus fracture often occurs. That's because this is the most porous portion of the bone. Shown on the screen is an example of a torus fracture of the radius bone. These fractures can be subtle, they're not always obvious, but at this portion of the bone right here, you can see it's whiter than the rest of the bone. That's because a force has been applied in this direction and the bone has basically piled up on top of itself, causing this torus fracture, the other classic form of an incomplete fracture seen in the pediatric population. And that concludes our video on the wrist.
Hello, everyone, and welcome to our module on the hand. Let's start by reviewing some important terminology about the hand. You need to know this terminology because in board questions, they will often describe a lesion but not show it in a picture. So the thumb is the first digit, the index finger is the second digit, the middle or longest finger is the third digit, the fourth digit is also called the ring finger, and then finally the pinky or small finger is called the fifth digit. When people refer to the volar surface of the hand, they're talking about the palm of the hand. And when they refer to the dorsal surface of the hand, they're talking about the back of the hand. And then finally, in terms of anatomic position, the thumb is lateral and the little finger is medial. If you look at this drawing here of the anatomic position, you see that the thumb is towards the outside, therefore it's lateral. The little finger is towards the middle, therefore it is medial. Let's talk about the bones and joints in the hand. The carpal bones are found in the wrist. I talk about these bones in more detail in the video on the wrist. Then as you move distally, you find the metacarpal bones, the proximal phalanges, the intermediate phalanges, and the distal phalanges. And all of your digits have 3 phalanges except the thumb, which only has 2. The joint between the metacarpals and the proximal phalanges is called the MCP joint, for metacarpal phalangeal joint. You then have the first of the interphalangeal joints, which is called the PIP. P stands for proximal interphalangeal joint. And then following that, you have the DIP joint, which is the distal interphalangeal joint. The major nerves that innervate the hand are the ulnar and median nerves. In general, the ulnar nerve innervates structures towards the ulnar bone or little finger. And you can just remember that the L in ulnar is for little finger. The median nerve in general innervates structures towards the radius or the thumb. And you can just remember that the M in median goes with the M in thumb. And if you could just remember this general principle shown in this picture here of the median nerve innervating structures towards the thumb and the ulnar nerve innervating structures towards the little finger, you can answer lots of board questions about nerve lesions in the hand. The muscles that perform hand movement can be divided into those in the forearm, which are called extrinsic hand muscles, and those in the hand itself, which are called intrinsic hand muscles. Let's talk about the intrinsic ones first. So this group includes the thenar group of muscles near the thumb. We'll talk about this group in a second. The hypothenar group near the little finger. The interosseous muscles, which are found between the digits. These are important for abduction and adduction of the fingers. And then finally, the lumbrical muscles, which are important for flexion and extension of the four fingers. Let's talk about those groups of intrinsic hand muscles one at a time. We'll begin with the thenar muscles. The thenar muscles are a group of three muscles. The three muscles are the abductor pollicis brevis, the flexor pollicis brevis, and the opponens pollicis. To work in with the thenar muscles, the thenar muscles are a group of three muscles. The three muscles are the abductor pollicis brevis, the flexor pollicis brevis, and the opponens pollicis. The word pollicis refers to thumb, so these muscles abduct the thumb, flex the thumb, and oppose the thumb. I'll talk about what opposition is in a minute. So all three of these muscles are associated with the thumb, and together they form the thenar eminence of your palm. This is a picture highlighting the thenar eminence of your palm. It's the fleshy part of your palm that you can feel if you press on your palm right near the wrist. All of these muscles are innervated by the median nerve, and that should make sense to you based on what we talked about earlier. The median nerve in general innervates structures near the thumb, including the thenar muscles. And this is important in board questions because when there is a median nerve lesion and these muscles lose their innervation, they will atrophy. So atrophy of the thenar muscles is often described in median nerve lesions. This is a picture showing opposition of the thumb. Opposition of the thumb means touching the thumb to the other fingers. This allows for precise movements, and this was thought to be a major step in evolution because it allowed us to carry out more precise and exact movements. Our next group of intrinsic hand muscles are the hypothenar muscles. This is also a group of three muscles. The three muscles are the opponens digiti minimi, the flexor digiti minimi brevis, and the abductor digiti minimi. All of these muscles move the little finger, and they form the hypothenar eminence of the palm, which is the fleshy portion of the palm highlighted in this picture here. And they are innervated by the ulnar nerve, which should make sense to you because they're on the little finger side of the hand, and they will atrophy in ulnar nerve lesions. The interosseous muscles are found between the bones of the fingers. That's why they're called interosseous. They're responsible for abduction and adduction of the fingers, but not the thumb. The thumb is moved by the thenar muscles that we talked about earlier. There are interosseous muscles on the palmar side of the hand and the dorsal side of the hand. The dorsal interosseous muscles are what perform abduction, and the palmar interosseous muscles are what perform adduction of the digits. And these muscles are all innervated by the ulnar nerve. And our last group of intrinsic hand muscles are the lumbricals. And this is the group that it's most high yield for you to understand because they're responsible for the hand abnormalities that occur in some nerve lesions. So the lumbricals are unusual in that they don't originate from a bone. They originate from tendons of a muscle called the flexor digitorum profundus. This muscle is found in the forearm. It's one of the extrinsic muscles that flexes the fingers. The role of these muscles is to flex at the MCP joints and extend at the interphalangeal joints. So in other words, what you can remember about the lumbricals is that they form an L shape of the hand. This is the L shape of the hand. The metacarpal phalangeal joints are flexed, that's right here, and the interphalangeal joints are straight or extended, that's shown here. So this is what these muscles do. They make your hand form an L shape as shown here. The median two lumbricals are innervated by the ulnar nerve. These are the two muscles near the little finger, and the lateral two lumbricals are innervated by the median nerve. These are the ones near the thumb. If you can remember that the word lumbricals starts with L and that the lumbrical nerve, these are the two muscles near the little finger, and the lateral two lumbricals are innervated by the median nerve. These are the ones near the thumb. If you can remember that the word lumbrical starts with L and that the lumbrical muscles make the fingers form an L shape, then it's easy to remember what happens when the lumbrical muscles lose their innervation. The fingers will take on the shape of clawed fingers. That's shown on the screen here. In clawed fingers, the metacarpophalangeal joints are extended because they cannot flex, and the interphalangeal joints are flexed because they cannot extend. This is what happens when the lumbricals lose their innervation. It's shown in this picture on the screen here. The MCP joints are extended and the interphalangeal joints are flexed. Now, as we'll see in a minute, if the ulnar nerve has a problem, it will only be the ulnar fingers that are clawed. And if the median nerve has a problem, it will be the median fingers that are clawed. But the point I want to make here is just a general point that the lumbricals make the digits take on that L shape. And when you lose the lumbricals, you get clawed fingers. Now let's talk about the extrinsic hand muscles. These are muscles that move the digits but are found outside of the hand in the forearm. We'll start by talking about the flexors. The extrinsic flexors are found on the underside of the forearm, and one of the most important is the flexor digitorum profundus muscle. This muscle has innervation by both the median and ulnar nerve. Some parts of the muscle are innervated by the median nerve. Those are the parts of the muscle that go towards the thumb. Other parts of the muscle are innervated by the ulnar nerve. Those are the parts that go towards the little finger, the same pattern we've been talking about throughout this video. The role of this muscle and all the flexors is to flex the digits, which means to make a fist like is shown in this picture on the screen here. The lateral two fingers or digits, the ones near the thumb, are controlled by the median nerve. The medial two digits near the little finger are controlled by the ulnar nerve. The extrinsic hand muscles that we've been parts of the muscle are innervated by the median nerve. Those are the parts of the muscle that go towards the thumb. Other parts of the muscle are innervated by the ulnar nerve. Those are the parts that go towards the little finger, the same pattern we've been talking about throughout this video. The role of this muscle and all the flexors is to flex the digits, which means to make a fist like is shown in this picture on the screen here. The lateral two fingers or digits, the ones near the thumb, are controlled by the median nerve. The medial two digits near the little finger are controlled by the ulnar nerve. The extrinsic hand muscles that are extensors of the digits are found at the back of the forearm. The role of these muscles is to straighten the digits. One of the most important is the extensor digitorum. This muscle is innervated by the radial nerve, and it strongly extends the MCP joints. So if you look at this picture on the screen with all the fingers extended, the MCP joints highlighted in green here are controlled by the radial nerve. The interphalangeal joints, when they extend, this is controlled by the lumbricals, as we talked about earlier, and the lateral two digits are controlled by the median nerve. That's shown in red here. The medial two digits are controlled by the ulnar nerve. Let's talk about flexion and extension of the wrist, because this is the extensor digitorum. This muscle is innervated by the radial nerve, and it strongly extends the MCP joints. So if you look at this picture on the screen with all the fingers extended, the MCP joints highlighted in green here are controlled by the radial nerve. The interphalangeal joints, when they extend, this is controlled by the lumbricals, as we talked about earlier, and the lateral two digits are controlled by the median nerve. That's shown in red here. The medial two digits are controlled by the ulnar nerve. Let's talk about flexion and extension of the wrist, because this is important in understanding nerve lesions that affect the hand. The major flexors of the wrist are controlled by the median and ulnar nerves together. There is a muscle called the flexor carpi radialis. This is controlled by the median nerve, and another muscle called the flexor carpi ulnaris. This is controlled by the ulnar nerve. And these muscles work together to flex the wrist, as shown in this picture on the left side of the screen. The major extensors of the wrist are all controlled by the radial nerve. It's all these muscles right here. So the only way you lose extension of the wrist and get wrist drop is by losing your radial nerve. And in the video on the brachial plexus, I talk about how wrist drop is a classic finding in a radial nerve lesion for this reason. Wrist deviation is a clinical finding seen in nerve lesions that involve the nerves that innervate the flexor muscles of the wrist. So if you look at this wrist on the screen here, remember that flexion of this wrist is controlled by both the ulnar and median nerves. But the ulnar nerve controls wrist flexors that are closer to the little finger side, and the median nerve controls wrist flexors that are closer to the thumb side. So this means that if you have a median nerve lesion, which means you've lost the ability to flex the wrist towards the thumb side, the hand will become ulnar deviated. This means deviated towards the little finger side.
Ulnar deviation of the wrist, especially with flexion, is a classic finding in a median nerve lesion. The opposite is true with an ulnar lesion. So if you have a lesion on the ulnar side, meaning innervation to the wrist flexors on this side are lost, then this means that the radial side muscles innervated by the median nerve will dominate and they will deviate the wrist in this direction. So if you know this, especially for board questions, it's very helpful. In a median nerve lesion and wrist flexion, the wrist will deviate to the ulnar side, and in an ulnar nerve lesion, the wrist will deviate toward the radial side. Now we're ready to discuss the clinical findings that can be seen in median and ulnar nerve lesions. Let's start with the median nerve. So remember what I said, this controls things near the thumb side of the hand. So in a median nerve lesion, there is motor loss near the thumb side of the hand. This includes problem with thumb movements because you lose the thenar muscles. You can also see problems with flexion and extension of the lateral fingers. Those are the fingers closest to the thumb, and this is because of loss of innervation to the lumbricals. In addition, there are sensory findings around the thumb. So around the thenar eminence and the lateral 3.5 fingers, you can see numbness or paresthesias. If you look at this picture on the screen here, everything shown here in brown is controlled by the median nerve. So you can see sensory symptoms here. This includes the thenar eminence. So if you examine a patient with a median nerve lesion, what you may see are the findings shown on this slide. At the thumb, you will see absence of flexion, abduction, and opposition. This is all done by the thenar muscles. Basically, the thumb will be paralyzed. And then in the lateral 2 digits or fingers, the 2 fingers closest to the thumb, there will be loss of innervation to the lumbricals, and this is going to lead to clawed lateral digits like we talked about before. So the patient will have difficulty moving those fingers at the thenar eminence and the lateral 3.5 fingers. You can see numbness or paresthesias. If you look at this picture on the screen here, everything shown here in brown is controlled by the median nerve. So you can see sensory symptoms here. This includes the thenar eminence. So if you examine a patient with a median nerve lesion, what you may see are the findings shown on this slide. At the thumb, you will see absence of flexion, abduction, and opposition. This is all done by the thenar muscles. Basically, the thumb will be paralyzed. And then in the lateral 2 digits or fingers, the 2 fingers closest to the thumb, there will be loss of innervation to the lumbricals, and this is going to lead to clawed lateral digits like we talked about before. So the patient will have difficulty moving those fingers, and they may take on a clawed appearance. Because of this pattern of weakness seen in median nerve lesions, there is a classic clinical finding called the Pope's blessing. It's also called the hand of benediction. This is shown on the screen here. So remember that patients with a median nerve lesion will have clawed symptoms on the median side of the hand. So these 2 fingers are extended at the MCP and they're slightly bent at the IP joints. That's the classic finding in a median nerve lesion. Now, if you ask the patient to make a fist, then the little finger side works fine and those fingers flex, but the fingers near the thumb cannot do so. So you get this finding on the screen, which is called the Pope's blessing. The thumb and lateral fingers cannot flex and the MCP remains extended near the thumb side. You don't have to memorize this finding. Just know that the problem here is that the fingers near the thumb are not moving normally, and that should let you know that it's a median nerve problem. Another finding you'll read about in your textbooks is called the ape hand. This is seen at rest when you examine the hand of a patient with a median nerve lesion. The thumb will be adducted because it cannot move, basically because it's lost its innervation. So it cannot oppose, it cannot abduct, so the thumb will just be stuck against the side. In addition, you'll see thenar atrophy as we talked. It's a median nerve problem. Another finding you'll read about in your textbooks is called the ape hand. This is seen at rest when you examine the hand of a patient with a median nerve lesion. The thumb will be adducted because it cannot move, basically because it's lost its innervation. You don't have to memorize this finding. Just know that the problem here is that the fingers near the thumb are not moving normally, and that should let you know that it's a median nerve problem. Another finding you'll read about in your textbooks is called the ape hand. This is seen at rest when you examine the hand of a patient with a median nerve lesion. The thumb will be adducted because it cannot move, basically because it's lost its innervation. So it cannot oppose, it cannot abduct, so the thumb will just be stuck against the side. In addition, you'll see thenar atrophy as we talked about before. This is called the ape hand because it's thought that apes do not have opposable thumbs, although in actuality they do. But the point here is it's like you have a primitive hand where the thumb cannot perform opposition. And you don't need to memorize this finding. Just remember that when the thumb is immobile or cannot move normally, that is usually a problem with the median nerve. So let's talk about some of the things that can cause a median nerve lesion. At the wrist level, a laceration of the wrist from trauma can cut the median nerve. In addition, many patients develop the carpal tunnel syndrome, which involves median nerve dysfunction at the level of the wrist. And I talk about this in much more detail in the video on the wrist. When you have a wrist lesion, the flexor muscles in the forearm will be intact, so you won't see any of that wrist deviation we talked about earlier, but you will see all the findings in the hand that we described for median nerve lesions. You can also develop a median nerve lesion if there is an elbow problem. One of the reasons this commonly occurs is because of a supracondylar fracture of the humerus. That's a fracture in the lower part of the humerus right above the elbow. If the median nerve is damaged at this location, you will lose innervation to most of the flexors and pronators in the forearm. For this reason, patients with elbow lesions involving the median nerve have a supinated forearm and flexion is weak. And then, as I talked about earlier, a very high yield thing to remember is that in a median nerve lesion that is proximal, like at the elbow, there will be ulnar deviation of the wrist, especially with flexion. This is because the flexor carpi ulnaris muscle maintains its innervation by the ulnar nerve and it can flex the wrist, but when it does so, it pulls it towards the ulnar side. The median nerve gives off a branch in the hand called the recurrent branch of the median nerve. This provides motor innervation to the thenar muscles, those muscles that move the thumb, but it provides no sensory innervation to the hand. This is a very superficial branch of the median nerve. It's near the flexor retinaculum, which is this structure right here. It's a fibrous band on the palm side of the hand that covers the carpal bones and forms the carpal tunnel, which we'll talk about in a minute. So if a patient has a superficial laceration of the hand, sometimes just this branch of the median nerve will be damaged. In this case, the thumb will be immobilized, but sensation will be normal. And you want to remember this for your boards because this is a variant on a median nerve lesion that you may see. Now let's talk about what happens when there is an ulnar nerve lesion. In this case, there is loss of abduction and adduction of the fingers because this is done by the interosseous muscles, which are innervated by the ulnar nerve. So the patient will not be able to fan out their fingers or bring them together. In addition, there's motor loss to the little finger side. This is the little and ring fingers. So the hyperthenar muscles will lose their innervation, and you can see atrophy of these muscles, and the median two lumbricals will lose their innervation. And then finally, there's also sensory loss to the little finger or ulnar side. If you look at this picture on the screen here, this portion shown in blue on the palmar side and also on the dorsal side is all provided by the ulnar nerve, so you can have sensory symptoms in these areas. So just like the Pope's blessing is a classic finding in a median nerve lesion, the ulnar claw is a classic finding in a patient with an ulnar nerve lesion. This position occurs when the patient has their hand at rest with the fingers straight and not flexed. Because of paralysis of the medial lumbricals, which are the lumbricals closest to the little finger, there will be extension of the MCP joints and flexion at the IP joints, and that will give an appearance like what's shown in the screen here, which is called the ulnar claw. And you don't need to memorize this, just notice that this patient's fingers are at rest and the patient is trying to extend their fingers. The fingers that are not functioning normally are near the little finger side, so therefore this must be an ulnar nerve problem. Ulnar nerve lesions can occur at the wrist level, also from lacerations, just like median nerve lesions. There's also a parallel to the carpal tunnel syndrome called the Guyon canal syndrome, which causes ulnar nerve symptoms at the wrist. And I talk about this in more detail in the video on the wrist. At the elbow level, you can have an ulnar nerve lesion if you have a fracture near the medial epicondyle. This is the medial epicondyle of the humerus, and the ulnar nerve runs right near here. So if you have a lesion here, in addition, you can have an ulnar nerve with a carpal tunnel syndrome called the Guyon canal syndrome, which causes ulnar nerve symptoms at the wrist. And I talk about this in more detail in the video on the wrist. At the elbow level, you can have an ulnar nerve lesion if you have a fracture near the medial epicondyle. Ulnar nerve lesions can occur at the wrist level, also from lacerations, just like median nerve lesions. There's also a parallel to the carpal tunnel syndrome called the Guyon canal syndrome, which causes ulnar nerve symptoms at the wrist. And I talk about this in more detail in the video on the wrist. At the elbow level, you can have an ulnar nerve lesion if you have a fracture near the medial epicondyle. This is the medial epicondyle of the humerus, and the ulnar nerve runs right near here. So if you have a lesion here, in addition to all the hand findings, you will lose the wrist flexor, the flexor carpi ulnaris. And as we talked about before, this will lead to radial deviation of the wrist, a very helpful hint in a board question. I'll finish this video by describing the ulnar paradox. You would think that a more proximal lesion of the ulnar nerve, like one at the elbow, would cause clinical findings that are worse than a more distal lesion like one at the wrist, but that is not the case for the ulnar nerve, and this is called the ulnar paradox. So in a proximal or elbow lesion of the ulnar nerve, the ulnar claw may not be seen. In other words, if you ask the patient to extend their hand and rest it on the table, you may not see the ulnar claw like shown in this picture. The hand may just lie flat on the table. The reason for this is because in proximal lesions of the ulnar nerve, you can lose innervation to the flexor digitorum profundus muscle in the forearm, and this muscle has fibers that flex the two little fingers. So when you lose that muscle because of a proximal lesion of the ulnar nerve, you may not see the ulnar claw because flexion at the IP joints will not be present. So what you will see is simply the ulnar digits are paralyzed, but there is no clawing. For this reason, it is said that proximal lesions appear less severe than those at the wrist, and this is called a paradox. And that concludes our video on the hand.
Hello, everyone, and welcome to our module on the lumbosacral plexus.
My
A plexus basically means a web.
My goodness. Okay. Sounds
Of
good.
nerves coming out of the spine. In the arm region of the spine, there is a plexus of nerves called the brachial plexus, which I talk about in another video. The plexus of nerves in the lumbar region of the spine is called the lumbar plexus. It consists of nerves that derive from the T12 to L4 level. It's found in the lumbar region of the spine. That's why it's called the lumbar plexus. And it supplies innervation to the skin and muscles of the lower limb. On the left side of the screen,
Sounds good, bro. It's gonna take like half an hour to finish.
is a drawing of the spine showing this web of nerves coming off of it in the lumbar region. That's the lumbar plexus. There's another drawing of this on the right side of the screen showing how nerve roots from the first lumbar and second lumbar and other levels come together in this plexus and form various nerves that travel down into the lower leg. The sacral plexus is a nerve plexus a level down from the lumbar plexus. It derives from nerve roots L4 to S4. It's found in the sacral region of the spine, and it supplies innervation to the skin and muscles of the pelvis and lower limb. And often the lumbar plexus and sacral plexus are considered together and simply called the lumbosacral plexus. On the left side of the screen is a drawing of the body showing you the lumbar plexus here and the sacral plexus found below that. And then on the right is a drawing of the sacral plexus showing all the different nerve roots contributing to nerves that travel down into the pelvis and lower leg. For the rest of this video, I'm going to go through many of the nerves that derive from the lumbosacral plexus. Questions about these nerves are generally easy points in the step 1 exam. If you just know what the nerve does and how it's commonly injured, you can usually get the question correct. So we'll start with the iliohypogastric nerve, which derives from the T12 to L1 level. If we go back to this drawing, the T12 level is here and the first lumbar level is here, and these nerve roots give rise to the iliohypogastric nerve and also a related nerve called the ilioinguinal nerve. This nerve is motor to two abdominal muscles, the internal oblique and the transverse abdominis muscles. They're shown in this picture at the bottom left side of the screen. This is the internal oblique here, and the transverse abdominis muscle is here. In addition, the iliohypogastric is sensory to the suprapubic region of the abdomen, which is also called the hypogastric region. That's how this nerve gets its name. This region is below the umbilicus and above the pubic bone. If you look at the picture on the bottom right side of the screen here, this is the hypogastric region below the umbilicus and above the pubic bone. It's also called the suprapubic region. This nerve is commonly injured in abdominal or pelvic surgical operations. For example, it can be injured in a laparotomy or a laparoscopic surgery. It can also be injured in hernia surgery or a hysterectomy. The reason this nerve is injured in these surgeries is because surgeons commonly make what's known as a transverse incision. That's an incision across the lower abdomen or pelvis like this. When this is done and the wound is sutured up at the end of the operation, the sutures can trap the nerves, especially at the edges around here, so the iliohypogastric can get injured on one side. In addition, the ilioinguinal can also be injured as well. The symptoms this leads to following surgery are usually sensory. It's burning pain or paresthesias like tingling that radiate from the incision site to the suprapubic area. And this is very easy to remember if you remember what I just told you, which is that this nerve is sensory to the suprapubic or hypogastric area. You can also sometimes see sensory problems in the labia or scrotum or the thigh. These areas are innervated by the ilioinguinal nerve. Moving on, let's talk about the genitofemoral nerve. This nerve derives from the L1 to L2 spinal roots. If we go back to this picture, we're now moving further down the lumbosacral plexus. We're now talking about nerves that come from the first lumbar and second lumbar region. And one of those nerves is the genitofemoral nerve shown right here. This nerve is motor to the cremasteric plexus. We're now talking about nerves that come from the first lumbar and second lumbar region. And one of those nerves is the genitofemoral nerve shown right here.
This nerve is motor to the cremasteric muscle in males. This muscle covers the testis and spermatic cord. It has two sensory branches. One is called the genital branch. The other is called the femoral branch. That's how it gets its name, the genitofemoral nerve. The genital branch, as the name implies, innervates the skin of the anterior scrotum in males, which is part of the genitalia, and in females, it supplies sensory innervation to the mons pubis and labia majora. The femoral branch supplies sensory innervation to the skin of the upper anterior thigh near the femur, and that's why it's called the femoral branch. This nerve is also commonly injured in abdominal surgery, often by retractor blades. So during surgical operations, an incision can be made like this, and a retractor blade will pull back the skin. Often the medical student is asked to hold the retractor blade, and that can, in some cases, damage the genitofemoral nerve. The symptoms this will lead to following surgery are in males, absence of the cremasteric reflex. To evoke the cremasteric reflex, you stroke the inner thigh and the scrotum rises on the ipsilateral side. If this does not occur, that suggests injury to the nerve supplying the cremasteric muscle. In addition, there may be decreased sensation over the anterior thigh. This region here is supplied by the genitofemoral nerve, and that's easy to remember because it's right over the femur. And in addition, there can be decreased sensation to the genital areas like the labia or the scrotum. Moving on, let's talk about the lateral femoral cutaneous nerve. This nerve tells you everything you need to know about it in its name. It's a pure sensory nerve from L2 to L3 that supplies the skin on the lateral side of the upper leg. In other words, the outside of the femur. That's why it's called the lateral femoral cutaneous nerve. And if we go back to this drawing, we're now moving another level down the lumbosacral plexus. We're talking about the lateral femoral cutaneous nerve, which derives from spinal roots at the L2, L3 level. I've put this picture of this obese man on the screen here because this is what you want to think of whenever you hear of the lateral femoral cutaneous nerve. This man with his big belly is the exact type of person who's going to have a problem with this nerve. The lateral femoral cutaneous courses under the inguinal ligament into the thigh, so it's easily compressed in people who have big bellies. Obese people, pregnant women can also be compressed by tight clothing. This is the type of situation where someone is going to complain of symptoms because of dysfunction of the lateral femoral cutaneous nerve. The pain syndrome that occurs when this nerve is compressed is called meralgia paresthetica. This is an outer thigh nerve syndrome. It involves sensory symptoms in the lateral femoral area, which is the area shown in red on this drawing. Patients will complain of burning pain in this area. They may complain of paresthesias, like numbness and tingling. They may also complain of hypoesthesia, which is diminished sensation. This is all related to compression of the lateral femoral cutaneous nerve, a classic symptom in someone with a large belly, like an obese patient or a pregnant woman. Next, let's talk about the obturator nerve, which derives from the L2 to L4 spinal roots. Here's the obturator nerve here. It derives its innervation from the fourth lumbar, third lumbar, and second lumbar spinal levels. The obturator nerve gets its name from the word obturare, which is Latin for to close. And if you know this, it's easy to remember that the obturator nerve is important for closing or adducting the thigh, meaning bringing the thigh back to midline so that the legs are closed together. The obturator nerve is motor to most of the thigh adductors, like the adductor longus, brevis, and magnus, also the gracilis, and the obturator externus. It also is sensory to a small portion of the medial thigh. If you look at this drawing on the screen here, much of the anterior medial thigh is supplied by a branch of the femoral artery shown in yellow here, but there's a small spot not shown in this picture right about here that is sensory from the obturator nerve. The obturator thigh brevis inducting the thigh, meaning bringing the thigh back to midline so that the legs are closed together. The obturator nerve is motor to most of the thigh adductors, like the adductor longus, brevis, and magnus, also the gracilis, and the obturator externus. It also is sensory to a small portion of the medial thigh. If you look at this drawing on the screen here, much of the anterior medial thigh is supplied by a branch of the femoral artery shown in yellow here, but there's a small spot not shown in this picture right about here that is sensory from the obturator nerve. The obturator nerve courses through the posterior pelvis. If you look at this drawing on the screen here, this is the obturator nerve here in the back of the pelvis. And for this reason, it can be injured during pelvic surgery. The classic way this happens of the femoral artery shown in yellow here, but there's a small spot not shown in this picture right about here that is sensory from the obturator nerve. The obturator nerve courses through the posterior pelvis. If you look at this drawing on the screen here, this is the obturator nerve here in the back of the pelvis. And for this reason, it can be injured during pelvic surgery. The classic way this happens is through injury from a trocar. This is a trocar shown on the screen here. It's a surgical instrument. It's a hollow tube, and you can insert it into the abdomen, and then you can insert other instruments through the trocar to get at structures in the back of the pelvis. So if the trocar is pushed too far into the back of the pelvis, it can damage the obturator nerve. And the symptoms this will result in following the surgery are weak adduction of the thigh and numbness in that small patch of skin on the medial thigh that's innervated by the obturator nerve. Next, let's talk about the femoral nerve. This nerve derives from nerve roots L2 to L4. If we go back to this slide, this is the femoral nerve shown here. It receives innervation from L2, L3, and L4. This nerve has both motor and sensory functions, and an easy way to remember what it does is to remember that it's named for the femur bone in the leg. So it is motor and sensory to structures that are related to the femur bone. So for example, it innervates many of the anterior thigh muscles. We'll talk about that in a minute. It innervates hip flexors and knee extensors, and its sensory functions are also closely related to the femur bone. Some of the hip flexors innervated by the femoral nerve are shown in this picture. First of all, the pectineus, which is shown right here, is a hip flexor. It's located very close to the femur bone, and therefore, naturally, it's innervated by the femoral nerve. The iliacus is part of the iliature. First of all, its hip flexors and knee extensors, and its sensory functions are also closely related to the femur bone. Some of the hip flexors innervated by the femoral nerve are shown in this picture. First of all, the pectineus, which is shown right here, is a hip flexor. It's located very close to the femur bone, and therefore, naturally, it's innervated by the femoral nerve. The iliacus is part of the iliopsoas, so the iliacus and the psoas muscle functions are also closely related to the femur bone. Some of the hip flexors innervated by the femoral nerve are shown in this picture. First of all, the pectineus, which is shown right here, is a hip flexor. It's located very close to the femur bone, and therefore, naturally, it's innervated by the femoral nerve. The iliacus is part of the iliopsoas, so the iliacus and the psoas muscle in the abdomen and pelvis come together to form a single muscle near the hip called the iliopsoas. The iliacus is innervated by the femoral nerve. And then finally, the sartorius, shown in this picture at the bottom left, is also innervated by the femoral nerve. The quadriceps are four muscles in the anterior thigh that extend at the knee. They're all innervated by the femoral nerve. The four muscles that make up the quadriceps are the rectus femoris and the vastus muscles, the vastus lateralis, medialis, and intermedius. If you look at this picture on the screen here, this is the rectus femoris here, the vastus medialis by the femoral nerve. Form a single muscle. Naturally, it's innervated by the femoral nerve. The iliacus is part of the iliopsoas, so the iliacus and the psoas muscle in the abdomen and pelvis come together to form a single muscle near the hip called the iliopsoas. The iliacus is innervated by the femoral nerve. And then finally, the sartorius, shown in this picture at the bottom left, is also innervated by the femoral nerve. The quadriceps are four muscles in the anterior thigh that extend at the knee. They're all innervated by the femoral nerve. The four muscles that make up the quadriceps are the rectus femoris and the vastus muscles, the vastus lateralis, medialis, and intermedius. If you look at this picture on the screen here, this is the rectus femoris here, the vastus medialis is here, the vastus lateralis is here, and the intermedius is not shown. It's deep to the rectus femoris. But all of these muscles attach at the knee and they straighten the leg. In other words, they lift the lower leg and extend at the knee, and they are all innervated by the femoral nerve. Sensory branches of the femoral nerve innervate the medial thigh and lower leg. There are branches called the anterior cutaneous branches of the femoral nerve, and they innervate the skin of the anteromedial thigh. That's this area shown in yellow on this drawing. The femoral nerve also gives off a branch called the saphenous nerve, which is sensory to the medial leg and foot. That's this region shown in red on the screen here. And the major clinical tie-in here has to do with saphenous vein stripping. So when patients go for cardiac bypass surgery, the saphenous vein is often removed from the leg and used as a bypass conduit. When this is done, it often damages the saphenous nerve, and this leads to numbness and the lower leg. And many of my patients in clinic who have had coronary artery bypass grafting surgery have numbness in their lower leg, and that's because the saphenous nerve was damaged, and that's a branch of the femoral nerve. Femoral nerve block is a technique used for anesthesia to the leg for surgical procedures. Basically, you inject a local anesthetic into the femoral nerve so that the patient will lose sensation in the leg for a surgical procedure. This is usually done together with block of the obturator and femoral cutaneous branches so that the entire lower leg will not have sensation. What you want to know about this for step one of your boards is the anatomy in the inguinal canal. So in the femoral region, in the inguinal canal, the structures go from lateral to medial, femoral nerve, followed by femoral artery, then vein, and then the lymphatic channel. So if you want to perform a femoral nerve block, you palpate the artery, which is easy to feel with your fingers. You can feel it in the groin of the patient, and then you inject laterally to that, which is on the outside. That's where the nerve is. Femoral region in the inguinal canal, the structures go from lateral to medial, femoral nerve, followed by femoral artery, then vein, and then the lymphatic channel. So if you want to perform a femoral nerve block, you palpate the artery, which is easy to feel with your fingers. You can feel it in the groin of the patient, and then you inject laterally to that, which is on the outside. That's where the nerve is found. And when you do this, the local anesthetic will block the femoral nerve.
Rarely, the femoral nerve can be injured by a process in the pelvis, like a pelvic fracture or pelvic surgery. And when this happens, the femoral nerve will be compressed and there will be weakness of all the muscles innervated by the nerve. So patients with femoral nerve injury will demonstrate weakness in flexion of the thigh and extension at the knee. Another high yield thing to remember about the femoral nerve is that is the nerve that participates in the patellar reflex. So shown on the screen is the patellar reflex. You tap on the patella or the kneecap with your hammer, and then the lower leg should kick out. That's extension at the knee, and that is mediated by the femoral nerve. So if you ever see a board question where they describe a weak or absent patellar reflex, that's usually a dead giveaway that they're talking about the femoral nerve. Other symptoms you can see can be sensory related to the femoral nerve. So this can include numbness, tingling, and burning, all in the thigh or knee, the areas that the femoral nerve innervates.
The sciatic nerve derives from the lumbosacral plexus levels L4 to S3. It's the largest nerve in the body. It's up to 2 centimeters wide, and it has both motor and sensory functions. And in the video on lumbar radiculopathy, I talk about the sciatic nerve in detail because many lumbar radiculopathy syndromes involve the sciatic nerve. What I'm going to talk about in this video, however, are the 2 branches of the sciatic nerve in the lower leg. Those are the common peroneal and the tibial. If you look at this drawing on the screen here, this is the sciatic nerve running down the back of the thigh. It branches into the common peroneal and the tibial nerve, and that's what we'll talk about next. The common peroneal nerve is also sometimes called the common fibular nerve. It's motor and sensory to whichever are the 2 branches. And in the video on lumbar radiculopathy, I talk about the sciatic nerve in detail because many lumbar radiculopathy syndromes involve the sciatic nerve. What I'm going to talk about in this video, however, are the 2 branches of the sciatic nerve in the lower leg. Those are the common peroneal and the tibial. If you look at this drawing on the screen here, this is the sciatic nerve running down the back of the thigh. It branches into the common peroneal and the tibial nerve, and that's what we'll talk about next. The common peroneal nerve is also sometimes called the common fibular nerve. It's motor and sensory to the lower leg. This nerve gets its name because fibula is the Latin word for clasp, and that's how the fibula bone was named because people thought it looked like a clasp. Peroneus is the Greek word for clasp, and therefore this nerve is often called the common peroneal nerve. The common peroneal nerve has a number of motor functions. First of all, it's motor to the short head of the biceps femoris, which is one of the hamstring muscles that flexes the knee. This is the only hamstring innervated by this nerve. This is a relatively minor role for this nerve. It also gives off a branch called the superficial fibular nerve, which supplies motor innervation to muscles of the lateral lower leg. The 2 muscles it innervates are called the fibularis longus and brevis, and these evert the foot. And then finally, it gives off a branch called the deep fibular nerve, which supplies muscles of the anterior lower leg. These muscles include the tibialis anterior, the extensor digitorum longus, and the extensor hallucis longus. I don't recommend you try to remember all these muscles. But what you should know is that these muscles are important for dorsiflexion of the foot and extension of the toes. So if you look at this drawing on the screen here, dorsiflexion of the foot means to move the foot and the toes upward, and that is done by the common peroneal nerve via the branch, the deep fibular nerve. In addition, the deep fibular nerve is motor to some of the intrinsic muscles of the foot. The common peroneal nerve supplies sensory innervation to portions of the lower leg and to the dorsum of the foot. If you look at this picture on the right side of the screen here, this area in yellow is supplied by branches of the common peroneal nerve that includes the dorsum or the top of the foot. Now let's talk about common perineal nerve lesions. And to understand these lesions, you need to appreciate that the common perineal nerve wraps around the fibula below the knee. Remember that perineal and fibula are words that derive from the same root, meaning a clasp. So common perineal nerve lesions often happen when there's pressure on the area near the fibula below the knee. So this could be from prolonged lying, like bed rest or surgery. Sometimes a cast on the leg can do this, and sometimes a fracture of the fibula at the neck can do this. The symptoms when there's a common perineal nerve lesion include foot drop. There's usually weak dorsiflexion. The foot can feel limp. The patient may complain of tripping or falling, and there's sensory loss on the dorsum of the foot and the lateral shin. And the way to remember this is just know that the word perineal means the same thing as fibula, and then just remember fibula and foot. So anytime there's a problem with the common perineal nerve, there's going to be a problem with dorsiflexion of the foot and sensation on the dorsum of the foot. And then you can also remember that this usually occurs when there's compression near the fibula. That's where the common perineal nerve runs. The other branch of the sciatic nerve in the lower leg is the tibial nerve. This courses down the lower leg posterior to the tibia. That's why it's called the tibial nerve. This is a drawing on the screen showing you how it courses down the back of the leg. And if you know that this is the course of the nerve, it's very easy to remember that it innervates muscles in the posterior leg. We'll talk about what those muscles are in the next slide. Now, when it gets down to the foot, it travels under the medial malleolus, which is this bump on the inside of your foot, and then it travels through a structure called the tarsal tunnel and supplies sensory innervation to the heel and the sole. The tibial nerve is motor to many deep and superficial leg muscles that are found in the posterior lower leg. I've listed the names of all the muscles on the screen here. You can also find them in this drawing here. I don't think it's very high yield to memorize the names of all these muscles, but what is important is that you understand what these muscles do. The muscles supplied by the tibial nerve are important for plantar flexion of the foot, which is shown in this drawing on the screen here. Also flexion of the toes, which means to curl the toes downward, and also inversion of the foot, which means to turn the sole of the foot inward towards the midline. And if you understand all that, it's very easy to understand what happens when there is damage to the tibial nerve. The nerve can be damaged at the heel from tarsal tunnel narrowing. This often happens following a heel or foot fracture or dislocation. The muscles in the posterior leg will be fine, but the sensory innervation of the foot will be affected. So the symptoms are mostly sensory, and they are symptoms like pain, burning, and numbness on the sole of the foot. Remember, the tibial nerve supplies the sole of the foot, and the common perineal nerve supplies the dorsum of the foot. Sometimes there can be tibial nerve damage at the knee. This is rare, but it can happen if there's a large Baker's cyst or trauma. In this case, all those muscles in the posterior leg will be affected. So the patient will lose plantar flexion, which means they can't stand on their toes. They won't be able to flex the toes, which is to curl the toes, and they will lose inversion of the foot. The last nerve I'll talk about in this module is the pudendal nerve, which comes from nerve roots S2 to S4, so way down low in the lumbosacral plexus. The word pudendal is Latin for to be ashamed, and if you know this, it makes it easy to remember that the pudendal nerve is the nerve supply to the genital area. In terms of motor innervation, it supplies the muscles of the perineum, the external urethral sphincter, and the external anal sphincter, as well as the levator ani. In terms of sensory innervation, it's sensory to the penis and clitoris and the skin of the perineum. The perineum is the floor of the pelvis between the legs, and shown in this drawing are a number of the muscles that are found in the perineum. You don't need to know what they all are, but you should know that these muscles are innervated by the pudendal nerve. So as you can imagine, this nerve is often injured from stretching in vaginal childbirth. After delivering a baby, women sometimes have perineal pain that's worse with sitting. They may have vulvar or scrotal pain, or they may have fecal or urinary incontinence, and this is all related to damage to the pudendal nerve. Pudendal nerve block is a technique used to numb the genital region in vaginal childbirth to reduce pain. This isn't done much in the modern era. It's largely been replaced by epidural anesthesia. But the way a pudendal nerve block is done is by injecting a local anesthetic into the area around the ischial spine of the pelvis. This is the point of entry of the pudendal nerve into the pelvis. So the way you do this is you have the patient lie in the lithotomy position. That's what's shown in this picture right here. And then through the vagina, you palpate the ischial spine of the pelvis, which is this point right here. And then you inject a local anesthetic in this region, and that will numb the pudendal nerve, and that will provide pudendal nerve block during childbirth. And that concludes our video on the lumbosacral plexus.